Hello, everyone. I am Nessa Gazeta. I am a pediatric dermatology fellow at Mayo Clinic, and I am very, very excited to kick off tonight's virtual journal club. This is hosted by Society of Pediatric Dermatology and PEDRA. So our format tonight is going to be that we're going to have Q&A after each presentation. And so we would like to ask you all to put your questions, please, in the Q&A box in the Zoom and not in the chat. Thank you for that. So for our next and first speaker here today, it is my absolute pleasure to introduce Dr. Marcus Boos. Dr. Boos is here today to share with us their paper, Management of Acne in Transgender and Gender Diverse Youth, Part 1 and 2. Part 1 is the gender affirming care and risk factors for the development of acne, and Part 2 is titled Unique Consideration and Strategies in Medical Treatment. Just a brief introduction for Dr. Boos. He's a pediatric dermatologist at Seattle Children's Hospital, an assistant professor in the Department of Pediatrics at the University of Washington. And he has a special interest in skin lymphomas, LGBTQ health, and he's an avid advocate of climate and environmental health. Dr. Boos, please.
Thank you so much for that introduction. I'm just going to share my screen with everyone and let me know if there's any issues anywhere. All right, you see everything okay there? That's not looking good?
Yes.
Okay, thank you. All right, so I'm really pleased to be able to kind of give a brief synopsis of this two-part review that was published in Peds Derm a few months ago. I'm going to try and hit the high points, but happy to answer any questions. The first thing that I like to emphasize when we're talking about this is, like, what is the point and what is the role of us as dermatologists in providing gender affirming care? And what we know, this is a study that was actually done by colleagues of mine here at Seattle Children's that looked at the mental health outcomes of children who receive gender affirming care. So they, were given puberty blockers and then actual gender affirming hormones. And what they found is that their mental health outcomes improved considerably. And the earlier that gender affirming care was provided, the better those outcomes were as far as things like depression, suicidality, anxiety, things like that. And, you might think to yourself, well, I'm not prescribing testosterone or, estrogen. So what role do I have in this? And I think that it's really important for us to remember the impact that we have on patients when we see them and recognize them as their full true selves. That really helps to bring down barriers to care for this population, seeking healthcare in general and dermatologic care more specifically. And you may have some patients that see you more frequently than even their, PCP, maybe not their gender care provider. But if you have a patient isotretinoin, for instance, you're going to see them monthly, and you want to make sure that every touch point that you have with them makes them feel good about who they are and is affirming for them in a way beyond just I'm giving you hormones. And I think that as dermatologists, we can play a really special role in doing that because our specialty is so visual. One other question that comes up is, well, how many trans or non-binary children might I see in my clinic? Previous estimates have been anywhere from around 1 to 2% of children identify as transgender or non-binary. But this was an interesting study that was done in Pittsburgh that actually asked this question, but did it in a two-part way, so that it wasn't just are you trans or not? Because some children might not sort of understand what it means to be transgender or identify as such, even though we might classify them that way, or they might classify themselves as non-binary and not see themselves as transgender that way. So really trying to capture this entire group, they asked this question, what sex were you assigned at birth? And then the follow-up question was, how would you define or classify your gender identity today? And when they asked the question as a two-part question, they actually found that about 9.2% in the study population, 9.2% of children who are high school age identified as, transgender or non-binary. And, one critique of this is, well, is in an urban area, maybe it's a liberal enclave, maybe there's social contagion, we just don't know. But they repeated this in rural Appalachia in West Virginia, and they found essentially the same thing, that about 7.2% of children there identified as non-binary or transgender. So this is a significant population that is just, waiting to access culturally humble and respectful care. And I think we have a great opportunity to provide it if we're willing to educate ourselves. So I think, one place I like to ground this discussion about how do we care for transgender and gender diverse youth is really understanding sort of like the risk factors at baseline. So we know that acne has, folks who have that have an increased risk of bullying, anxiety, depression, loss of social attachments, and transgender identity also is associated with those things. So, we want to be mindful of how impactful our care can be in reversing, these poor mental health outcomes. And one other thing that I think is really important to keep in mind is that we know that gender identity influences how kids feel about their skin, and specifically like how they treat their acne. So that actually holds implications for how you may deliver care or treatment regimens that you plan on providing. I want to talk about that a little bit more. So this is a study that we did here at Seattle Children's, asking teenagers anywhere from like 12 to 21. Like, how does your gender influence your like how you take care of your skin and how you perceive yourself? And both cisgender and transgender females both mentioned they feel a greater pressure to keep their skin clear. There's sort of like an idealized beauty standard that they had to sort of like aspire to. And if their skin didn't look good, they often felt worse about themselves. And, I think about this too, right? People are like, well, like, gender affirming care, it's so controversial, but we provide gender affirming care all the time, right? If the social expectation is that females have like Neutrogena Neutrogena commercial ready skin and like a dewy complexion, and we're trying to help them achieve that, that is like a gender affirming thing that we're doing. And so I think it's really easy to get caught up in like how this is politicized, and the people who do that or who politicize it are, I feel, bad actors intentionally doing that sort of thing. But we provide gender affirming care all the time in dermatology, and this is really no different. When we talk about transgender males, there's a little bit of a spectrum of how they feel about their skin with respect to acne. And for some, they just identify as like, I have acne now, I didn't have it before. And so I start, like using medications I didn't have to. It was sort of like matter of fact. The second blurb that you can see here, it says, like, I feel kind of weird buying skincare products because that's something that like, it's supposed to be like a feminine thing. It's like, guys don't really need to do that. And also, like having this acne sort of really affirms for me that I am transitioning, that I am, becoming a man, because boys are supposed to have like greasy skin and acne. So it's sort of like a complicated relationship that this individual has with their acne. These last two talk about, like hygiene habits, like I don't take as many showers or I don't do skincare because it's feminine, quote unquote, and it makes me dysphoric. And so I really think that like it's important to keep those things in mind, right? If you have a child who is unwilling to use lotions or solutions or creams or washes because the whole act of actually like cleansing their skin induces gender dysphoria because they're transgender males and they perceive that as a feminine activity, like that's going to be a problem. And this is, one of the more like sort of revolutionary things for me in the study, and something that has changed my practice, where I actually bring it up and talk with my patients about it and just say, hey, like some people feel this way. This may or may not be you, but does this affect you? Because I need to know. I want to make sure that I provide you a regimen for your acne that really addresses that and that you're able to do. And, sometimes, right, like we prefer just use topical medicines for acne if we can get away with it. I don't think any of us would be like, hey, like here's your prescription for doxycycline and call it a day. And so if we can kind of like work with the patient through that, help them challenge these like held social beliefs that they have about skincare being a feminine thing, and maybe allow them, like permission and an access point to start using topical medicines and seeing it not as a gendered thing. I think that can be really powerful, but we won't do that unless we ask, unless we talk about it and have space for those sometimes challenging conversations. A couple things I just wanted to talk about just briefly. I know we don't have like a ton of time since there's 3 different presentations tonight, but pubertal blockade versus gender affirming therapy. So pubertal blockade is using a GnRH agonist like Lupron. That is typically only provided by a gender affirming care provider when children are Tanner 2, and this is reversible. The one concern with being on it for too long is that it can impact bone density accrual over time. But in general, it just puts a pause on puberty, which then resumes after the medicine is withdrawn. But when we're talking about gender affirming hormones, which is testosterone or estradiol, and when trans feminine patients are given estradiol, they're also given spironolactone often, that is not fully reversible. So we are getting secondary sex characteristics that can't be totally changed. So that is something that is much more, like we want to be more intentional when working with children who make this choice, because it isn't something that we can necessarily fully undo. And depending on the institution, this is usually offered at around like 13 to 16 years of age. So let's get down to the acne nitty gritty. Like, what are the risk factors for the development of acne in transgender or gender diverse individuals? So the first and foremost, the big one is masculinizing hormone therapy. So testosterone, that, you will see much more, at least in my experience, and I think this is borne out in literature, that individuals who receive testosterone therapy as opposed to estradiol therapy, you're going to see a lot more acne in that population. The studies about these risk factors that we have are largely done in adults, but that includes young adults, and some preliminary studies that folks are doing in younger populations, I think, bears this out as well. But it seems like the younger age of therapy initiation and serum testosterone levels of greater than 630 nanograms per deciliter are particular risk factors. Smoking also seems to increase the risk of developing acne. And the studies on weight and BMI are mixed. Some say like a higher BMI, some say a lower BMI are triggers. So I think that's a little bit up for debate still. And then there's a question of the use of chest binders. And this, I think, has been answered a little bit more completely now. This is a study it was a survey study asking folks, like, how long have you been binding for, and how many years, how many days per year, and how many hours per day. And they took that information and categorized it into what they call binding years, which effectively it's a similar analogy to like pack years of smoking. So one binding year is if you bound every day for a year for 10 hours. And for those of you who are unfamiliar with what chest binding is, this is often used by transmasculine and sometimes gender diverse folks to reduce the appearance of breast tissue. So it can be like a sports bra, or sometimes like very, very constricting garments that are just worn for extended hours at a time to reduce the appearance of breast tissue in folks who were assigned female at birth. And what I just want to point out is about a third of patients within the first year of starting use of a chest binder will develop acne, and about 50% of them will get itchiness as well. So there are things that folks will do to sort of supplement the hormone therapy that can also be risk factors for acne, is worth discussing as well. By and large, when you're treating acne in gender diverse populations, the sort of like typical ladder of benzoyl peroxide, a topical retinoid, things like clindamycin, that it's not going to change no matter what the individual's gender identity is. First line oral medicines like doxycycline or oral antibiotics, also there's really no change with that. But I wanted to touch on two topicals that may be relevant to this population. So one is topical dapsone, that in studies in cisgender children, it seems to be more effective in females. And the idea there is that androgen stimulation induces sebum production and just more of an inflammatory component that makes that type of acne a little bit more recalcitrant to the anti-inflammatory effects of dapsone. So this may be of greater benefit for trans feminine patients who are on estradiol, if they just need a little bit of extra to kind of get over the hump. So something that you might consider, although there haven't been any studies done in transgender populations to confirm this. And then there's clascoterone. That's relatively newer on the market over the past couple of years, a topical anti-androgen that's applied twice daily. It's a topical anti-androgen, so it makes rational sense that if we are providing someone, testosterone, and this is a way that we can sort of limit its effects on the skin. The caveat to that is we don't know if you're putting it on your face, for example, is that going to impair the development of like facial hair and other signs of secondary, like virilization. So that's, again, another study that I'm interested in what the implications are, but no one has done that yet. But something that I would recommend sort of using with caution, or at least letting the children that you work with know that it may impair the development of facial hair. But another possibility as well for transmasculine patients on testosterone therapy. Let's talk about other oral agents. So I wanted to talk about combined oral contraceptives. So, we use this for cisgender females, but it's actually a reasonable thing to use also for transmasculine folks. That's why I have the little male sign in the corner. And there's a few benefits for it just broadly. One is that it does help for menstrual suppression. And it's important to note too that it does not prevent masculinization. So taking an OCP is not going to prevent testosterone from doing its thing. However, many patients will reject it because they perceive it as like a female hormone, or sometimes the pill with the it's very sort of like characteristic packaging. Folks who are not like out to roommates or family members may reject it because of that. And even though reducing menstruation may be helpful for gender dysphoria, these pills can also induce breast tenderness, and so that may trigger dysphoria. So it is something that would be individualized. The venous embolism risk is no different for trans folks compared to cisgender females, as far as we know. But there is, again, concerns about bone mineral density. And for me, the biggest question is like, is it effective? And that's some place where we also don't have a whole lot of data. You can imagine that if we're like flooding the zone, so to speak, with testosterone by giving it exogenously, reducing just a little bit of androgen production via the use of combined oral contraceptives might not have like a huge impact. But regardless, it is safe to use this in the transmasculine population. Spironolactone, as I mentioned, is often a component of gender affirming feminizing therapy. So that's something that may already be prescribed by a child's gender care provider. But this works by just decreasing testosterone levels and inhibiting testosterone binding to androgen receptors. And so that can be helpful as well for acne. I think we're all in this group relatively aware of the side effects of spironolactone. It's typically well tolerated. But again, breast tenderness can be an issue that may not be seen as a bad thing for folks who are trans feminine. Just sort of like having a sensation like I have breast, it actually may be welcome. But the one thing that I think is really important for us to remember, if you do prescribe this, I think kind of twofold. Number one is you don't want to add on spironolactone if someone is already receiving spironolactone. I think it's worth always reaching out to the patient's gender affirming provider to be like, hey, like, what do you think? Like, is it safe to increase the dose of spironolactone and have the conversation? But I would never do anything sort of like independently. And that goes for COCs as well. You always want to have good back and forth communication with their gender provider. But the other big thing is polyuria. We don't necessarily think about this all the time because it's just like, hey, like, yeah, it's a diuretic. I might have to go to the bathroom more. But this can really be an issue for trans and gender diverse children because sometimes there's not a safe bathroom for them to use. Especially in states, I think Florida today actually outlawed gender affirming care for minors officially. Kentucky recently passed a bill that included that trans children had to use the bathroom of their sex assigned at birth. There's lots of really harmful bills that affect kids. And if there's not a gender neutral restroom to use, or even if there is, like, is it accessible? That is something that you want to think about. Because if a child needs to go to the bathroom, like, every hour, and there's not a bathroom that they feel safe using, then spironolactone may not be a great choice. And we talked about breast tissue development, which can be a side effect that is welcome in trans feminine patients. Let's talk just briefly to finish up with isotretinoin. It has lots of effects that work well to treat acne and can be really helpful for folks who develop cystic acne while on testosterone. There are reports of depression, suicidality, and isotretinoin. There's been a number of sort of meta-analyses in the last year or two that have looked at this question. I think it's clear that by and large, most patients who get on isotretinoin have improvement in their mood and reduction in self-harm and things like that. However, there are always the exceptions. So I think it's just really important to talk about it with your patients. I would not let that be a barrier to prescribing isotretinoin. You could consider using like a PHQ-2, just like a quick mental health exam, just to ask how things are going. But again, part of that conversation more globally about like, how is your acne affecting you? How is, minority stress and stigmatization affecting you? Was this going to help you because you'll feel better about your skin? There's so much that goes into it. And it's so important to take that time to talk with your patients about it. There is also concern about scarring and wound healing. There was a consensus statement in JAMA Derm a few years ago that a number of members of our Society of Pediatric Dermatology were participants into. And, the takeaway from that really is, I think that the sort of concern about scarring and long-term wound healing issues is a bit overstated based on the evidence that we have. That being said, if someone were to have a phalloplasty or a medioidoplasty, like these are not insignificant surgical procedures to have. And so something that's more complex, maybe you don't want to add anything that could potentially impede wound healing. So I think that's just a really important conversation to have with a patient, with potential surgeons that could be involved. But I would not take an absolutist approach to things depending on where a child or a person is in their transitioning journey. Registering for iPledge, thanks to the efforts of folks in the AAD Expert Resource Group for LGBTQ Health, the iPledge system, there have been issues with it since they revamped it about a year ago. But one thing that has been much better is that we have taken away the gendered nature of classifying patients, and now it's just, can you become pregnant versus can you not, instead of having to classify as male, female of childbearing potential, or female not of childbearing potential, which was problematic for folks who were transgender males because they could get pregnant but they are not female. So how do you classify those and still maintain their autonomy and their sense of self-determination and the justice associated with that? So that is no longer an issue. That being said, a monthly pregnancy test may induce dysphoria in this population as well. So again, it's just really important to sort of telegraph, what are the potential pitfalls? What are things that may be a challenge for you? And make sure that folks know that before they start that journey, and that they can handle it. And then again, just to say this out loud, testosterone does not equal birth control. That does not count as a method of birth control when registering for iPledge. Two other things to think about with transmasculine or gender diverse patients. We mentioned chest binders. If patients are willing to take off their chest binders, then that may help with acne. So it's worth having that conversation. And then also just discussing with their gender provider and the patient themselves, is it possible that we reduce the dose of the testosterone or maybe consider a different method of delivery? It does not seem that method of delivery, whether it's IM, sub-Q, or topical, makes a huge difference in development of acne, but I don't think the data is that rigorous yet. But that may be an option, or considering reducing the dose. But again, lots of patients, if they're doing well and they're seeing signs of masculinization and virilization, may be a little reluctant to reduce their testosterone dose. So that's the big highlight. I would encourage you to read both articles. It's something that I feel very passionately about, and unfortunately, every day, I think our care becomes more and more relevant to this population. And yeah, I'm happy to take any questions, and I'll stop sharing my screen.
Thank you so much, Dr. Booth. That was a fantastic overview of your paper. I really, truly enjoyed reading it. If that is okay with you, because we were running a little short on time, would that be okay if you answer those questions in chat? And I think we have two questions and we can answer them in the Q&A box. And with that, I would like to go next up to Dr. Mancuso from University of Michigan to introduce our next speaker and article. Thank you
so much. Hi, good evening, everyone. I'm Jenny Mancuso. I have the pleasure tonight of introducing Dr. Esteban Fernandez Faith, who will be speaking about the incidence and clinical factors associated with ulceration and infantile hemangiomas. Dr. Fernandez Faith is an associate professor of pediatric dermatology at Nationwide Children's in Columbus, Ohio, and also the program director of the Pediatric Dermatology Fellowship. He is an active member of PEDRA and the Hemangioma Investigator Group. Welcome, Dr. Fernandez Faith, and thank you for participating tonight.
Thank you very much. It's great to be here with you guys. Thank you for the invitation, for the opportunity to share our study. So let me share my screen here. Let me know if you see it okay. So this was a collaborative study of PEDRA, and we were looking at ulceration in infantile hemangiomas, and particularly looking at the incidence of ulceration and also the clinical factors associated with ulceration in infantile hemangiomas, particularly now that we are using beta blockers, or since we started using beta blockers for these patients. So as a little bit of background, before we were using beta blockers, so before 2008, the incidence of ulceration in these patients was somewhere between 15 to up to 30%, really depending on which study you looked at. And this is really the incidence at tertiary referral centers. One of the largest studies before the beta blockers were introduced was a study by the Hemangioma Investigator Group, published back in 2007. They looked at a little bit over 1,000 patients, and the incidence in this study was almost 16%. So our question was, is the incidence of ulceration different now? The other question that we have is, are the clinical features that we're seeing with ulceration different from what we saw before? So that study also showed us some important risk factors for development of ulceration. So we know that the larger the hemangioma is, the higher the risk for ulceration. Mixed hemangiomas, segmental hemangiomas are also more likely to ulcerate, and also certain locations, the lip, the neck, the diaper area. These were all clinical risk factors that were defined or found before we started using beta blockers as risk factors for ulceration. So again, we had two main questions. One was, is the incidence of ulceration different now that we are using beta blockers? Are we making any differences by using beta blockers in these patients? And are the clinical features associated with ulceration different? So these were our two main aims. This was a retrospective study at 3 tertiary referral centers, 3 PEDRA centers. And it's important to take a look at the study period. So it already feels like it was a while ago. So the study period was from 2012 to 2016, and we'll talk a little bit about this in the limitations of the study. So we had a little bit over 1,700 patients that we were able to look up, and basically we looked at all the patients who came with a hemangioma. And of course, we looked at the ones who did have an ulceration and the ones who did not have an ulceration. So of the 1,700 patients, 1,500 roughly were what we consider the controls, meaning they did not develop ulceration, and 197 were the cases or the ones that developed an ulceration. So this gave us an incidence of 11.4, which compared to the previous study, to the study before beta blockers were used, it was a significant difference. So that kind of answered our first question: is the incidence of ulceration different now? That was something that we were kind of had a sense of that in our clinical practice, but there weren't any studies that had previously looked at this information. Then the other question was, are the clinical features different from what we used to see? So when we looked at the features in our patients, in unadjusted analysis, we found all of these features to be associated. Race and ethnicity, particularly Black race, superficial hemangiomas, segmental and partial segmental hemangiomas were more likely to ulcerate. Again, larger hemangiomas. And as far as locations, we found the diaper area and the upper extremity were more likely to be associated with ulceration. But when we took all these factors together and kind of did a multivariable analysis, these were the features that kind of maintained that statistical significance. So Black race, partial segmental hemangiomas, larger size hemangiomas, particularly more than 5 centimeters in diameter. And as far as the location, particularly the diaper area, was still statistically significant in our cohort. One of the findings that I think is very important to highlight is the age at presentation. So particularly the age of presentation when it comes to the different races and ethnicities in our patients. So the median age of presentation was 16.3 weeks. And if you look at this table, you can see that Black patients presented the latest, almost 6 weeks after the median, or 6 weeks after most patients. And Black patients did represent a small portion of the entire cohort, just about 4%. But I think this really kind of highlights some of the healthcare barriers that some of our minority patients have. So this is definitely something that's worth looking into it and making sure that we are closing that gap. It is also important to consider what were the management practices that were used for this cohort of patients. Of the entire cohort, about 55% did receive a beta blocker and did not develop ulceration. Almost 10% received beta blocker for treatment of ulceration, meaning the beta blocker was started after the ulceration. And a very small number, 1.7%, developed ulceration after the beta blocker was initiated. So there's still a very small minority of patients where treatment with beta blockers cannot prevent ulceration. So why are we seeing a lower incidence of ulceration? And this is probably multifactorial, but the big change between the pre-beta blocker and the beta blocker is that we're using beta blockers, that we have a better treatment option for these patients. So the use of beta blockers is likely driving the lower incidence in these patients. Now, we also know there's better education now. There's been publications of guidelines, of consensus statements. So hopefully improving the care of these patients. When we look at the age of the patient, we can also think, well, maybe before beta blockers, patients were presenting a little bit too late, and now we're seeing them a little bit earlier. And we are seeing a little bit earlier, but I don't know that the difference in the age, it's like somewhere between 1 to 3 weeks, is really not that significant. So it's probably what we're doing for these patients, how we are managing these patients, what's really driving the decrease in the incidence. Now, when we look at the associated factors, I think this is something that is very important to take into context. And so with this information, I don't want to give the message that, oh, a lip hemangioma is no longer at risk for ulceration. Well, the nature of hemangiomas hasn't really changed. What has changed is what we do for these patients. So I don't want you to take home a message of, oh, we don't have to treat a lip hemangioma anymore because of risk of ulceration. What's probably happening is that we're probably treating more lip hemangiomas. And because we're doing that, we're lowering the association of with ulceration. So it also doesn't mean that segmental hemangiomas are no longer at risk for ulceration. Probably that's not the case. We're probably treating more segmental hemangiomas, and because we're treating them, we are seeing as not as strong association with ulceration. So it is important to take this really into context, and that's why we were very careful in not in using associated factors as a way to describe this finding, as opposed to risk factors, which is what was used before beta blockers were started to use for these patients. Some important limitations of our study, it was retrospective study, so there's some limitations inherent to that type of methodology. This was done at tertiary referral centers, so this is not information that we could necessarily generalize to the entire hemangioma population. But doing it this way really allowed us to compare the incidence with the previous studies that were done at tertiary referral centers. And I mentioned before, the study period is also important to consider. You know, it already feels like it was a while ago, 2012 to 2016. And we have probably changed what we're doing for these patients now. We have continued to change. So an important milestone that happened right in the middle of the study was the FDA approval of propranolol for infantile hemangiomas that happened in 2014. So that could have also changed the management of these patients. So what I want to say with this is that if we were to do this study again, you know, with what we're doing now for our patients, if we do it now, we would probably continue to see some changes, and I would think that we would continue to see some even further decrease in the incidence of ulceration in these patients. So a couple take-home points here. One is that the incidence of ulceration is lower, and the lowering in the incidence and the changes in the features associated with ulceration are likely related to the changes in the management for these patients, particularly with the use of beta blockers. There's still a lot of questions that we need to answer with regards to ulceration. We still don't really know exactly what causes ulceration. We don't know what are all the mechanisms behind ulceration. We know that proliferation is part of it, but it's not all of it. So we need to understand better why ulceration happens in these patients. And there's still several patients. There's still many patients who have ulcerations that can be very challenging. Some patients who present with pretty aggressive ulcerations, and we really need to try to figure out better treatment options for these patients as well. Really want to acknowledge the collaborators of this study and PDRA that really made this study happen. And with that, I thank you. And I don't know if we have time for questions. Let me stop sharing here.
Thank you so much, Dr. Fernandez. That was wonderful. I guess I feel very lucky to be practicing in the post-propranolol age, because these are just some of the hardest patients, and it's it's very heartbreaking watching families go through this. So thank you for getting more information for all of us on this important subject. Would you say, has anything in your clinical practice changed after writing this paper, or how you approach patients?
Yeah, so that's a great question. So I don't think anything has particularly changed, except that I think it encourages us to be more proactive in treating these patients when there is an indication for treatment. It doesn't mean that we have to treat every single hemangioma, but to really take those patients who we feel are at high risk for ulceration and be more proactive in treating those patients, and we will probably continue to see a lower incidence in this type of complication, which, as you mentioned, it's very painful. It causes a lot of distress to the family, a lot of anxiety to the parents, There's other risks, the risk for scarring, the risk for infection. So it has a lot of extra layers of complexity when this happens.
Yeah, absolutely. We have a question from Angela Lopez. It said the cases of hemangioma ulceration during the beta blocker treatment are a minority, but in your practice, is there like personal management to avoid this?
That's a really good question. So yes, it was a minority of patients. It was only 30 patients of the entire cohort, so it was a very, very small number. I think what's important is to realize that sometimes that ulceration is just about to happen, and no matter what you do, it's going to happen, right? So sometimes you're just seeing them right before the ulceration happens. I think an important clinical clue is to look for that white hemangioma whenever there is a little bit of pallor on the surface of the hemangioma that tells you that surface it's about to ulcerate. So be more kind of vigilant with those patients. With other a previous study that we did before this one, we found that perhaps lower doses or a lower titration of systemic beta blockers, if there is an indication for systemic beta blockers, might be helpful to treat ulceration. So that is perhaps something that could be considered. Somebody who is truly at risk for ulceration and who needs a systemic beta blocker, maybe go slower on the titration up of the dose. Other important factors to consider, particularly areas where there is friction in the diaper area or in the neck. I always tell parents to try to keep the hemangioma very well lubricated to try to prevent a little bit of that friction that could end up being one of the factors associated with the ulceration.
Thank you. Those are great. Another question, it was from an anonymous attendee, but it says, do you think ulceration of a hemangioma would change the rate of initiation of propranolol?
I don't know if they mean the rate of dose escalation, maybe, or the rate of initiation.
I think my guess is that they're saying like you would prescribe it more frequently.
So for ulceration, so the previous study that we did, that we looked at different treatment options. We looked from just wound care alone to TIML to systemic beta blockers to more complex treatment options. And even wound care alone was found to be very helpful in this patient. So without any treatment. So wound care is definitely one of the kind of the important pillars in the treatment of ulceration. It's difficult to give a very kind of generic or a recommendation that would work for everyone. Whether you treat with a topical medication when there's a potential high risk of systemic absorption, or if you go to a systemic medication, there's a lot of other factors that have to be taken into consideration. Is that hemangioma causing functional problem at the same time? Is that hemangioma around the eye, for example, or around the mouth, and it's causing functional problems, feeding problems? So those are cases that you would definitely think of starting a systemic beta blocker more readily. If it's a hemangioma that's ulcerated but maybe not causing a lot of issues, it's a small ulceration or erosion, I think you have a little bit more leeway in your treatment options there.
Wonderful. Yeah, that makes sense. Oh, there's one more question here from Joseph Lamb, and it's a different study from JAMA Dermatology that you also authored about clinical features, prognostic factors, and treatment interventions for ulceration. And the question was, does this study support your previous article regarding shorter healing time with doses of less than 1 mg per kg per day of propranolol?
Yeah, thank you for that question. So that was the kind of the original study that then really sparked the idea of doing kind of this follow-up study looking at all the patients. So we did not, it's a good question, and the data that we have, we didn't really look into this particular, to answer this particular question. We did not look specifically at the doses that were used for all of these patients. And also, we did not look at the rate of titration. So those are two very important factors when we're looking at whether the dose of systemic beta blockers makes the ulceration heal faster or not. So we did not look into those factors. So this study doesn't really directly support our previous findings.
That makes sense. All right. Well, thank you so much for presenting this evening. That was wonderful, Dr. Fernandez Faith. We had some great questions, and now I would like to introduce Dr. Katie Sue. She is the Pediatric Dermatology Fellow at University of Massachusetts. Thank you.
Thank you. And I am very excited to be welcoming our next speakers this evening, Brenda Carillo and Dr. Lindy Ross, who will be presenting their recent publication entitled Pediatric Pulse Dose Corticosteroid Therapy Dosing and Administration in the Treatment of Alopecia Areata, a Review of Literature from Pediatric Dermatology. Brenda is a fourth-year medical student at the University of Texas Medical Branch John Seeley School of Medicine, and she recently matched into dermatology residency at UT Austin Dell. And Dr. Ross is an assistant professor in the dermatology department at the University of Texas Medical Branch. Her interests include general adult and pediatric dermatology. So welcome, Brenda and Dr. Ross, and thank you so much for participating in this evening's Journal Club.
Thank you so much for having us. I'm going to go ahead and share my screen. Okay, does that look all right?
It's still loading.
Let me give it one more try. Okay, how's that?
It still just says it's loading.
1 second.
Brenda, would you like me to try to share my screen?
Sure, if you're able to do it.
Let me see.
Yeah, I think we can see it there. Sounds good. All right. Well, thank you all so much for having us. Our article is titled Pediatric Pulse Dose Corticosteroid Therapy, Dosing and Administration in the Treatment of Alopecia Areata, a Review of the Literature. So as we know, the management of severe alopecia areata can be very challenging as it is prone to relapse. And for mild cases, we very often use topical and intralesional steroids, and oral corticosteroids are often reserved for refractory cases due to their associated side effects. Pulse dose corticosteroid therapy is a modality in which we use a high dose corticosteroid in an intermittent manner rather than daily in hopes of enhancing the therapeutic effect and reducing side effects. However, the use of PDCT in the treatment of AA in children has not been systematically reviewed in the literature. So the purpose of our study was to assess the available literature detailing the treatment regimens and doses used in PDCT in children with AA, their response to treatment, and side effects. So we conducted a search of PubMed and Ovid using the terms alopecia areata, corticosteroid, and pulse. And the search was limited to 8 articles. We did not have a date limit, and it included studies only involving patients from 0 to 18 years of age. Any articles that included adjuvant therapies, such as methotrexate, and any studies that included both adults and children were excluded. So we found 8 total articles, and some of these had 2 regimens. So in total, we found 6 IV regimens and 4 oral regimens. So we're going to start with the IV regimens. This first one looked at 2. So they used dexamethasone 1.5 mg per kg per day IV, either for 1 day out of the month or for 3 consecutive days out of the month for 6 months, but could be continued to 9 or 12 months, depending on the patient's response. They also used topical clobetasol 6 out of 7 days of the week, 3 weeks on and 1 week off, and oral ranitidine for any GI side effects. So what they found was that those that used it for the 3 consecutive days out of the month had significantly greater 100% regrowth. So you can see 52.8% in the 3 consecutive day group had 100% regrowth compared to only 16.2%. And that difference was also significant in the greater than 50% regrowth. Unfortunately, about 33.3% of these patients relapsed at 27.7 follow-up months. And then for the side effects, they were usually minimal, and none of these required stopping the treatment. And in conclusion, they found that it was well tolerated with long-lasting results. So Kish and Vici also looked at IV regimens. So they both used methylprednisolone 5 mg per kg twice a day IV, infused over 1 hour for 3 days. And Kish found that 5 out of 7 patients had 100% regrowth, and none of them relapsed at 12 to 30 months follow-up. However, Ubici looked at this in the long run of 44.3 mean months. And unfortunately, 6 out of the 7 patients that had more than 60% regrowth relapsed. So they thought this might not necessarily be the solution for the long term. Smith also looked at an IV regimen. So they used methylprednisolone 30 mg per kg per day IV for 1 day out of the month for a maximum of 3 cycles. And 10 out of 18 patients had more than 75% regrowth, but 7 out of the 10 relapsed at mean 15.5 months. So again, they thought it might be useful in the short term, but not in the long term. Friedland used methylprednisolone 8 to 10 mg per kg per day IV for 3 days monthly for a maximum of up to 10 cycles. And they also had some results, but a pretty high relapse rate of 88.8% at 24.9 mean months. But they also found that those who did better significantly had disease duration of less than 6 months, age of onset less than 10 years of age, and multifocal AA compared to more severe forms like aphasia and totalis or universalis. So moving on to the oral regimens, which are what are more practical for us to use in clinic, Lalosevic looked at an oral regimen. They used dexamethasone 5 mg per kg prednisolone equivalent, and they used it 1 day out of the month for 6 months, but they could continue it to 9 or 12 months depending on response. They also used topical clobetasol 6 out of the 7 days and oral ranitidine. So we can see that 41.5% of the patients had 100% regrowth. And then for those who had alopecia plurifocalis, and Dr. Rez, you could move on to the next, yes. So those with plurifocalis, and these patients still had 30 to 60% scalp involvement, but it was in focal patches. 65.5% of them had 100% regrowth, and that was maintained at the long-term follow-up. And in more severe forms, 35.1% of those patients had greater than 75% regrowth. So they concluded that this was safe and effective in the long term. So Sharma looked at 2 regimens, and this was based on age. So the first regimen was for patients that were 12 to 18 years of age. They gave them prednisolone 300 milligrams every month for a minimum of 3 doses. And then the next regimen was for patients that were aged 3 to 11, and they were given betamethasone 5 mg per kg prednisolone equivalent monthly for 3 to 8 cycles. So overall, they found that about 60% of the patients had 75 to 100% regrowth at 6 months. And 2 patients in each group relapsed, but fortunately about 3 of those patients were able to be successfully treated with topical steroids or intralesional steroids. The side effects were mild headache, transient giddiness, and hyperacidity. So they recommended this for widespread AA. And our last study was a case report. This was a 9-year-old male with alopecia totalis. He was given methylprednisolone 15 mg per kg for 3 days bi-monthly for 12 pulses over 22 weeks. And then he was given 3 more maintenance pulses after 4 weeks, and then 2 more after 3 weeks. And he had a very localized relapse, and that was treated with topical or intralesional steroids. And he achieved 100% regrowth at 6 months, and it was maintained at the 1-year follow-up. And the only side effect was transient hyperglycemia. So overall, about 50% of the patients had more than 50% hair regrowth. And the most commonly used steroids were dexamethasone and methylprednisolone. Several of the studies showed that the results were pretty promising in the short term, but not necessarily in the long term. However, those that use dexamethasone, which is longer acting, more potent, along with concomitant clobetasol and more pulses up to about 12, they concluded that these regimens were effective for the long term, and that ranged from 12 to 132 months. So based on the articles that we looked at, the one that we would recommend would be the dexamethasone prednisolone 5 mg per kg equivalent once a month for 6 months, and can be continued to 9 or 12 months, depending on patient's response, with the concomitant clobetasol. So this is a study that had the highest number of patients. It had 65 patients, and they all had more than 30% scalp involvement. And 56.9% of the patients had more than 75% regrowth. They had a good follow-up. It ranged from 12 to 132 months, but the mean was 96 months, and 69% of the patients in the study were able to follow up. The side effects were, again, pretty mild, just a headache that was easily treated with over-the-counter medication. And then it is an oral regimen, which again is easy and practical to administer. Another thing we found, as we mentioned with several studies, is that those with multifocal AA tended to do better than those with alopecia ophiacis, totalis, and universalis. And those with short disease duration, 6 months in some studies and less than 12 months in other studies, also did better. And those who had more severe forms of AA, or those who had longer disease duration, sometimes they did have regrowth, but it often required more pulses, and they were often more prone to relapse. So in conclusion, we found that PDCT appeared to be well tolerated, and it could be considered for children with AA, especially early in the disease, and those with multifocal AA. Specifically, this is the regimen that we recommended from the ones that we reviewed. And the limitations were that, unfortunately, there was a lack of control groups, there was no standardized scoring system across the studies, and there were varying degrees of disease severity and duration. So more research is definitely needed, and it's important to consider that there are many more AA treatments now available. So perhaps this could be one of your starting regimens, or it could be something you might consider as you're bridging to one of the other modalities. And it's, of course, it's very important to monitor for patient response and any adverse effects, and always educate the patients on the risk of relapse. Those are our references. Thank you.
Thank you so much, Brenda, for that wonderful presentation and for so nicely summarizing all of those really helpful clinical takeaways. I'd love to hear if there's sort of, I noticed that the age ranges in those studies was pretty variable. What's sort of the youngest age that, you guys are feeling comfortable initiating these pretty high dosed pulsed corticosteroids?
I think in the studies, some of the youngest ages that were included were down to age 3 years of age. I haven't really done it for younger kids than that. I do find that I always try to assess my patients psychosocial distress and how they're feeling about their alopecia areata when I'm trying to decide how much risk to put on them as far as what treatments I choose, or, the shared decision making we have with the parents. And a lot of times my children that are younger than that, they're not really bothered by their alopecia areata enough to go and jump into some of these medications that might have a lot of heavy side effects to them. I would really be interested in hearing from the audience too, if anyone has any practical tips. I think this is the kind of discussion that I feel like I hear a lot of people have different regimens in their lectures that I listen to at the SPD or at the AAD, but there aren't really studies about them. So the only things that we could recommend were the things that we could find in the literature. But I know sometimes in clinical practice, maybe we don't exactly follow these regimens that we recommended.
Great, thank you. And comment from Tor Schwader saying that we used to use pulse steroids for hemangiomas. I hope to live long enough to say the same for AA.
Yeah, I was going to say that's the only literature I've seen for these like really young patients using pulse steroids is for the treatment of infantile hemangiomas. I've never actually done that. I've done intralesional steroids, but I've thankfully not had to use pulse steroids for them for infantile hemangiomas since I live in the era of propranolol as well. I'm really thankful for that.
And are there any clinical scenarios where you would be choosing to initiate IV over oral corticosteroids?
Honestly, I've never in my patient population had that ability to. I mean, like for me to do that, I would either, I don't know, have to admit them or get a PICC line, or I don't know how I would even do that. So I'm not sure how these studies were actually practically done, or if the children had IV access for some other reason. I was kind of interested in that, but that was the most of the literature was actually in these kids with IV access somehow. So I'm kind of confused by that.
And I know in these studies, you specifically mentioned that all of these studies excluded other sort of adjuvant treatments, but I feel like in our clinical practice, we're so often administering sort of multiple treatments. So are you in your clinical practice administering other like treatments like topical or oral minoxidil?
For sure. Yeah, I use a lot of oral minoxidil, topical minoxidil, and then of course with bridging to JAK inhibitors. Those are the things that I think would be really important and good to like study the combination effects. But I think a lot of our patients, when they're so desperate to get hair regrowth, they're not just doing one thing, right? They want the kitchen sink. They want all of the treatments all at one time to get as much potential for regrowth as they can. So I think it would be interesting to look at those studies. It was just harder to include some of those regimens because they were on so many different adjuvant therapies. We thought it would kind of complicate the data and make it a little harder to give you a concise and practical clinical take from it.
And I know sort of the conclusions from this study was that in general, these high doses of steroids seems to overall be pretty well tolerated. Maybe the main side effect I think you had mentioned was headaches. And in your clinical practice, what are sort of the most common side effects that you tend to be seeing, or sort of what's your approach to counseling parents and patients about side effects?
I feel like maybe I'm an oversharer. Like with side effects, I want my parents and patients to make really informed decisions. So I do tend to like tell them the whole spiel, all the things that I tell even my adult patients about blood sugar and blood pressure. I say usually that's not as big of an issue for a pediatric population, but definitely like mood changes, grumpiness, irritability. I think those are the things that my parents actually tell me about, and they notice, and I'm like, sorry. But also, I do think it's important to kind of emphasize like the side effects of steroids, because there was an article in 2021 in Pediatrics where they talk about even like one pulse of steroids, they were given for a lot of different reasons for inpatient indications. So it wasn't just for alopecia areata or in dermatology clinics, but they had increased risk in this large cohort of patients for like sepsis and pneumonia and GI bleeding. And these things that like we don't really want to think about us causing these harms to our children, but I think it is really important to kind of think of all these things, like make really thoughtful decisions and make informed decisions too.
And then question from anonymous attendee, any subjective thoughts comparing pulse dose oral steroids to oral JAK inhibitors?
I think our progress with JAK inhibitors is so amazing. I've had patients that are so happy with regrowth. And I think whenever we're stacking side effect risks, I mean, I think JAK inhibitors have a longer term effect and use. But side effects, I think, are kind of significant, and we have to discuss them all. But I do think that JAK inhibitors have a longer outlook than these pulse oral steroids that, as we can see from these studies, tend to have high relapse rates.
And thank you, Dr. Antaya, for this, for your comment that you've been using Pulse Pred 5 mg per kg dose once monthly on Saturday morning after breakfast. And overall, reasonable option, very well tolerated in your 2 decades of experience. The most common side effects that you're seeing, hyperactivity. So thank you for that.
My kids have hyperactivity every Saturday morning after a bowl of cereal. So I could definitely see that would be a common side effect. I really appreciate that comment because I think it kind of fits in line with what we saw in the studies. So you're doing great evidence-based medicine, and it's good to hear that, you know, after years of experience, it still holds up.
Great, thank you. And I think I'll turn it back over to Nessa to conclude the evening.
Oh, thank you so much. This was really amazing. I just want to thank you all of our fabulous speakers today and tonight for sharing their research with us. I want to thank you, the moderators, for picking these articles and helping us coordinate this session. A big shout out and thank you to SPD and PEDRA for hosting, and thank you so much for this amazing audience for attending and asking all of these thoughtful questions and triggering all of these conversations and discussions. So remember, these journal clubs happen quarterly. We do hope that we see you all on the next sessions. Have a good night and thank you again.